Hello and welcome to My Opthal Teacher. This is the last lecture in the series of diabetic retinopathy, and I've tried to cover all the important topics from your as far as your exams are concerned and a little bit extra topics. So now this is basically about the clinical trials in diabetic retinopathy and more important from the postgraduate point of view. So let us begin. Before we jump on to the trials in general, let us know that there are three types of regimen of anti-VEGFs that are used by clinicians and used in studies also. So fixed monthly regimen in which the anti-VEGF is injected every month, right? Pro Renata and Treat and Extend. These are the other two which we'll be discussing subsequently. Let us talk about the cons of the fixed monthly regimen. So basically, a lot of financial burden, a lot of follow-up is needed, okay, and it is not a very feasible option, right? You often lose patients to follow up if you're going to inject them monthly. Plus the of course side effects, albeit rare, they're still there, right? Besides, follow up is an issue because the patient obviously has to visit every month, right? And also bear the cost. These anti-VEGFs are costly, so fixed monthly regimen is not really a good idea, right? So the scientists, the clinicians, they came up with two better regimens, PRN and treat and extend regimen. Remember, whenever we are talking about response, a general rule of thumb is 10% reduction in the central macular thickness from baseline at 4-week follow-up, or improvement of visual acuity by 5 or more ETDRS letters. Okay, it can be both, it can be either. This is the general rule of thumb when we say response or no response. So let us know about PRN and treat and extend regimens. So PRN means, the literally the meaning of the word is as and when required. So basically what the doctor does here is that 3 months of initial loading injections are given. Okay, for 3 months a monthly regimen is followed. Three loading injections are given, and this is known as a loading dose. After that, the patient has to visit every month but not necessarily get injected. So after the first 3 months, follow up every month with what? With an OCT to measure the CMT and the visual acuity, but inject only when needed until there is complete drying of the macula. So that is about pro renata. Okay, treat and extend. Monthly injections are given till stability. Follow-up gradually extended by 1 to 2 weeks based on the CST, or the central subfield thickness, or the central macular thickness, and BCVA. So basically in treat and extend, we are literally treating and extending. Okay. So 1 month, every month, the injection of anti-VEGF is given until stability is attained, that is a central macular thickness of 350, say 350 microns, which is the threshold. It is achieved, or there is no further increase, there is no further worsening of visual acuity, there is no further increase in the CMT. That is what is stability. So once the stability is achieved, you increase the follow-up. You no longer call the patient every month. You increase the follow-up gradually by 2 weeks based on CST and BCVA. So if the patient is maintaining CST and BCVA and has attained a dry macula, you can keep on increasing the follow-up gradually by 2 weeks. Maximum extension is 12 weeks. So the maximum period between two visits can be 12 weeks. Now, if in between these follow-up periods there is worsening, that is there is a significant increase in the macular thickness or worsening of the visual acuity, you decrease minimum 4 weeks. Okay, you decrease the follow-up period, you start seeing the patient more frequently, and the minimum would be 4 weeks, right? And if required, you inject, right? So decrease the follow-up plus inject, that is treat and extend. So pro renata is basically a reactive approach, and treat and extend is a proactive approach. If worsening is seen, inject. Pro renata only when needed. Follow up every month, inject when needed. Treat and extend, keep following up and extend the follow-up periods and inject if necessary. This is proactive. As soon as worsening is seen, you Why proactive? Because as worsening is seen, you reduce the follow-up period. You keep following up the patient, you gradually increase the follow-up intervals, but if you find worsening, you reduce the follow-up period and inject if necessary. So basically, this one is an improvement over Prorinata, and the advantage is that the treatment burden is reduced. So let us talk about clinical trials now. So there are trials related to metabolic control. Please remember I've highlighted all the names of the trials in green. So diabetes control and complications trial. Okay, we already saw this in the previous lectures. So tight blood sugar control in patients with type 1 diabetes reduced the incidence of macular edema by 29%. Okay, and the application of focal laser by 50%. That is the DCCT trial. UKPDS trial, the mean systolic blood pressure reduction of 10 mmHg and a diastolic reduction of 5 mmHg over a median follow-up of 8 years led to 35% reduction in retinal laser treatments. Both trials are important. You have to memorize the whatever I have conclusions I have written. Just know the names of the trials and just remember that these are the conclusions. These are the only two trials that you need to remember related to metabolic control. Okay, bare minimum for your exams. Trials related to bevacizumab, the first one is the BOLT trial, which stands for bevacizumab or laser treatment. 1.25 bevacizumab was compared with macular laser as control over a period of 2 years. Significant improvement in visual acuity was seen in the bevacizumab at 1 year as well as 2 years. Okay. Trials related to ranibizumab. There are so many trials. Rise and Ride, Restore, Reto, Reveal. All of these trials basically proved that ranibizumab is better than laser, both visual acuity and the central macular thickness wise, after a 1 year period. Okay. Now this performance continued, that is, it persisted over 3 years in the Rise and Ride, Restore, and Reto trials, and it persisted over 5 years. That is, ranibizumab continued to perform better than laser over a period of 5 years in Protocol I. Protocol I also demonstrated that there is no benefit of laser if using as adjunct to intravitreal ranibizumab therapy for diabetic macular edema. Remember, we are talking about diabetic macular edema only here. Okay, these are all related trials, anti-VEGF trials related to diabetic macular edema. Related to aflibercept, the important ones are the Da Vinci and the Vivid and Vista trial. So Da Vinci, primary purpose of the DME and the VEGF trap eye investigation of clinical impact. This is the full form. So it is a phase 2 trial to determine whether different doses and dosing regimen of intravitreal aflibercept were superior to focal laser photocoagulation over a 24-week study duration in eyes with DME. And it was found that different doses, that is 4 weekly versus 8 weekly, both were equal in terms of efficacy. Okay, so 4 weekly dose versus 8 weekly dose of aflibercept, both equal in terms of efficacy. Vivid and Vista was to compare the efficacy of intravitreal aflibercept with macular laser photocoagulation for diabetic macular edema over a period of 3 years, in which aflibercept performed better. The recommended dose of aflibercept for DME is 2 mg given every 8 weeks after 5 initial monthly injections. Okay, so 5 initial monthly injections is the loading dose. After that, every 8 weeks. This is for the aflibercept regimen for diabetic macular edema. Protocol T. Now, Protocol T, now that we have seen the three important anti-VEGFs, there is a protocol for you to compare the three agents. Okay. So this was again a randomized multi-center clinical trial, compared intravitreal aflibercept. Now I'm using short forms. Aflibercept 2 mg, bevacizumab 1.25 mg, and ranibizumab 0.3 mg. Okay. So these were the inclusion criteria: above 18 years with type 1 or type 2 diabetes, center involving diabetic macular edema, and visual acuity from worse than 20/30 to up to 20 by 320. What did we do with these patients? We randomized them to aflibercept, ranibizumab, or bevacizumab for a period of 2 years, and we measured the changes in their visual acuity versus changes in macular thickness. So the key takeaways in the 2 year period of Protocol T were that all the three drugs show visual improvement. When baseline visual acuity is good, visual improvement is similar in all groups. When baseline visual acuity is bad, aflibercept performs better for 1 year. But this superiority of aflibercept over ranibizumab at 1 year is not maintained after 2 years. Okay? Eyes treated with aflibercept required less macular laser. right? Total number of injections approx 10 in 1 year and approx 5 in 2 years. We've already seen this. So the conclusion was that aflibercept performed better in eyes with poor visual acuity when compared to the other two drugs. And this superiority of aflibercept was maintained only for 1 year. By 2 years, the result was equivalent to ranibizumab. Now, anti-VEGF versus PRP as primary therapy for PDR. So let us talk about anti-VEGF as primary therapy for PDR. Okay, we talked about DME. Now, what if anti-VEGFs are also the line of treatment for PDR? So, anti-VEGF were compared with pan-retinal photocoagulation. I've already discussed pan-retinal photocoagulation with you people. So there were these three trials, okay, recovery trial, clarity trial, and DRCR protocol S. I have already mentioned clarity trial and DRCR protocol S when we were talking about PRP. So the conclusion was that there is visual acuity improvement, there is DME prevention, visual field loss is not there obviously with anti-VEGFs when compared to PRP, and the need for future PPV or additional PRP is also reduced with anti-VEGFs. Okay, so basically in a gist or in layman's terms, I would say that anti-VEGF is now taking over PRP as the primary therapy for PDR also. Okay, this is something new. Next, we have the DRCR studies. DRCR stands for Diabetic Retinopathy Clinical Research Network Studies. They have several protocols. Okay, so we've discussed a few. We are yet to discuss a few more. But I have covered the important protocols, especially postgraduates. Please note the important protocols. That is protocol T, S, U. Please go through the slides again. So this is just a revision, this slide. So protocol T was a comparison of the three anti-VEGFs, and I already told you aflibercept better than ranibizumab in 1 year. But after 2 years, there wasn't much difference. Then protocol I compared ranibizumab monotherapy for DME. Okay, these were the four arms: laser alone, ranibizumab plus laser, ranibizumab plus deferred laser, and IVTA plus grid or focal laser. All these four arms were compared. So this is also an important protocol because it is comparing an anti-GF with all the other existing modalities of DME. So monthly ranibizumab proved best for DME, and focal or grid can be, if needed, it can be deferred for a period of 24 weeks. So when we say prompt means immediate as soon as DME is seen, and deferred means you continue to give ranibizumab for a period of at least 24 weeks, you wait and then you can give deferred laser. So ranibizumab alone still performed better than prompt laser. Treatment regimen, again, this is just an overview. So basically, monthly intravitreal anti-VEGFs are given till the visual acuity is 6/6 and the OCT is showing a dry macula. Okay. Stability means visual acuity or OCT is not worsening. It is unchanged for the last 2 to 3 visits. Okay. So in treat and extend, we treat until stability is achieved. That is why it is a proactive approach, right? Remember, we read that in treat and extend versus pro renata. So this is the treatment regimen, that is PRN or treat and extend, whatever you're following. After that, PRN if DME recurs or worsens. Okay, pro renata, that is inject if DME recurs or worsens, and or you can do a treat and extend, that is extend the follow-up regimens. Okay, now what if something is not responding to your anti-VEGFs for say 24 weeks? The maximum extent in the TNE protocol, I think, was 12 weeks. So that is how long the interval can be between two visits. So if the response is still not coming, then we label it as recalcitrant DME. And for recalcitrant DME, what you can do is change the molecule, that is change the type of anti-VEGF you are using. You can switch to steroids if the patient, especially if the patient is pseudophakic. Check control of diabetes or hypertension. Sometimes it is not the anti-VEGF that is the culprit. It is the patient's own metabolic control that is the culprit behind no response. Do an imaging for peripheral non-perfusion areas. Sometimes, see, VEGFs have a good response to edema, right? But what if there are non-perfusion areas, areas which are already ischemic? What happens then? The anti-VEGF will not work on those areas. You can try for a PRP laser. Or last but not the least, consider other diagnosis. For example, X-linked recessive macular telangiectasia in cases of non-response. Now we come to dexamethasone implant. So there was triamcinolone, which was introduced in the era of lasers. And now there is a new one, that is dexamethasone implant. The commercial name is Ozurdex. It contains 0.7 mg dexamethasone. It is also a steroid. It is FDA approved for diabetic macular edema in 2014. So these are the indications, okay? Recalcitrant or persistent DME, vitrectomized eyes with macular edema, patients requiring reduced treatment burden, recent history of stroke and pregnancy. These are the general indications for steroids. This slide is important for undergraduates also. See, this is the result of dexamethasone implant. Okay, you see the difference in both central foveal thickness as well as visual acuity. The protocol related to this is protocol U. Those already on ranibizumab therapy do not benefit from addition of a dexamethasone implant. Okay, that is protocol U. There is another study related to the dexamethasone implant, that is the Bivordex study. Okay, the postgraduates can look it up. So both protocol U and Bivordex study. See, I've mentioned it over here. So Bivordex study, Ozurdex was compared with bevacizumab. There is no significant difference in visual acuity or CMT. Okay, so one can say that Ozurdex is non-inferior to bevacizumab at a period of 2 years, with the advantage of fewer number of injections because this is longer acting. So it lasts for a period of 3 to 6 months. But the problems of cataract and raised IOP are there. So it is going to be the treatment of choice only in pseudophakics, and you have to monitor IOP regularly so as to avoid secondary glaucoma. Some other non-biodegradable steroid implants are Retisert and Iluvian. So that was dexamethasone. Then Retisert has fluocinolone acetonide, a pellet of 0.59 mg, and it continues to release. So basically all these steroid devices, no, all these depot preparations, they contain a few mg of the steroid and they release a few micrograms per day, right? So they are long lasting. So Retisert is 30 months, but it requires incisional surgery, and Iluvian is for a year and it can be inserted with a 25 gauge needle. So just to summarize again, undergraduates, this is important for you. A summary of the treatment, even if you forget everything else, at least try to remember this picture and write it in your exams. So things started with laser. So grid laser is for non-center involved DME. It can be prompt or deferred. Deferred for how long? 24 weeks. PRP or panretinal photocoagulation is for severe NPDR, PDR, anterior segment neovascularization, and neovascular glaucoma. That is about the lasers. Then injections. Injections can be anti-VEGF or steroids. Anti-VEGFs are the gold standard now for macular edema. So based on vision and CMT, the anti-VEGFs are injected. There is two types of regimen, Prorenata and treat and extend. Aflibercept better than ranibizumab and bevacizumab at a period of 1 year, but equivalent over a period of 2 years. Steroids are also a type of injection given in recalcitrant DME. If cost is an issue, one can give triamcinolone, else one can give Ozurdex. And when you're giving steroids, you have to monitor for IOP and cataract. So this is a very basic slide for the undergraduates to remember. And postgraduates, of course, have to elaborate and you have to know about the trials also. They have to know about the PRN and TAE, the meaning of PRN and treat and extend in detail, the criteria for vision and CMT, okay? And the definition for center involved and non-center involved DME, recalcitrant DME, the various types of intravitreal steroids, okay, and what releases what, so on and so forth. So some future strategies. Uh, there are these tiny molecules called DARPins, design ankyrin repeat proteins. They are small non-immunoglobulin proteins that bind the target proteins with high affinity and specificity. That is the specificity. That is the definition. So one such DARPin marketed by Allergan was abicipar. It showed a lot of visual acuity improvement in diabetic macular edema at 12 weeks, but it had high rates of ocular inflammation. So it was voluntarily withdrawn from the market, and some improvement is being worked upon. Then comes gene therapy. In gene therapy, subretinal injections of a recombinant adeno associated vector. This adeno associated vector is the most common vector which is being used in gene therapy for retinal diseases to deliver various types of genes. So, a recombinant adeno associated vector encoding this particular protein, soluble FLT1. This soluble FLT1 protein produces a soluble form of VEGF receptor 1. So, this behaves just like VEGF trap I. So VEGF A, B, PIGF are bound in much the same way as aflibercept. So this is the gene therapy. What is being tried for gene therapy? Then alternative drug delivery methods are there. For example, there are controlled drug delivery system using nanoparticles loaded with anti-VEGF. And there are slow release devices, one of which is even FDA approved. The name is Susvimo, FDA approved for NAMD, not diabetic macular edema. What is it? It is a ranibizumab containing port delivery system. Okay, so it has to be implanted. So surgically implanted pumps which deliver up to 100 programmable doses of intravitreal drugs, and every 6 months you have to go for a refill. The device stays in the eye and one can just refill the pump. Okay, so these are some of the future strategies. It will be good to know. So conclusion of the entire lecture is early detection and initiation of therapy for diabetic retinopathy is important, because as we have seen in so many trials that poorer visual acuity at baseline performs poorer with anti-VEGFs or any other treatment for that matter. Better visual acuity at baseline remains better at final results also. Systemic control, most essential. There are studies on this. Okay, the UKPDS and the DCCT studies. When you write your answers, you can quote. Then FFA, OCT, Octa, wide field imaging are diagnostic tools. So in the third lecture, I've talked very extensively about about the diagnostics and imaging in diabetic retinopathy. Please go through that lecture. Anti-VEGF is now the gold standard for center-involved DME, and there are different types of regimen: monthly, Pro-Renata, and treat and extend. Steroids are preferred in recalcitrant macular edema that is not responding to the above. Vitrectomized eyes and pseudophakic eyes. Vitrectomized eyes, there is less risk of secondary glaucoma. Pseudophakic eyes, there is less risk of cataract, rather no risk of cataract. Initiate panretinal photocoagulation or scatter laser for severe NPDR or PDR. There is a protocol on this also. I have discussed the protocols on PRP in the section on PRP itself. Vitrectomy, early vitrectomy when indicated. When is it indicated? When there is an ERM or a vitreomacular traction or a tractional RD. Future anti-VEGF therapies for diabetic retinopathy may utilize advanced methods of drug delivery system such as Vabysmo, Susvimo, not Vabysmo, I'm sorry. Vabysmo is the commercial name for faricimab. Susvimo and nanoparticles and pegylated proteins, that is DARPins, and newer drugs may target VEGF molecule. So that's about it, and I hope that in this entire series of lectures on diabetic retinopathy, I cleared at least some of your doubts. So please continue to watch my videos on my ophthalmic teacher, and thank you for your support.